Classifications of 4 CTDs: SLE, systemic sclerosis, dermatomyositis, polymyositis, rheumatoid arthritis. Number 1, systemic lupus erythematosus. This condition is an autoimmune disease where the body's own immune system mistakenly attacks healthy tissues. The damage happens because immune complexes get deposited in different organs like the skin, kidneys, brain, and joints. Imagine a 22-year-old woman who comes with a red rash across her cheeks that worsens in sunlight, painful joints, and later develops swelling in her legs due to kidney involvement. That's lupus nephritis, one of the most serious complications. Other problems may include seizures, psychosis, pericarditis, or pregnancy losses when antiphospholipid antibodies are present. Blood tests such as ANA and anti-double-stranded DNA help confirm diagnosis and also monitor disease activity. The challenge with lupus is its unpredictability. Flares can happen suddenly and cause permanent organ damage. So the key danger lies in ongoing monitoring and early treatment to protect vital organs. Number 2, systemic sclerosis, also known as scleroderma. This is a disease where small blood vessels are injured, fibroblasts are overactive, and collagen builds up, leading to fibrosis of skin and organs. A very common early sign is Raynaud's phenomenon, when fingers turn white, then blue, and finally red on exposure to cold. Let's take an example. A 35-year-old woman develops Raynaud's for several months, then notices tight, shiny skin on her hands. Later, she develops shortness of breath due to lung involvement. This is typical of diffuse systemic sclerosis, where lung fibrosis and renal crisis appear early. In contrast, the limited form progresses slowly, but after years, it may cause pulmonary hypertension. Antibodies help us predict the type: anti-centromere in limited disease, anti-SCL70 in diffuse. The most feared complication is scleroderma renal crisis, with sudden malignant hypertension. Here, starting ACE inhibitors quickly can be life-saving. Number 3, dermatomyositis and polymyositis. These are primarily muscle diseases with autoimmune inflammation, leading to progressive weakness. Patients often struggle with simple tasks: climbing stairs, rising from a chair, or even combing hair. For example, imagine a 45-year-old man who says, "Doctor, I can't lift my arms to wear a shirt." On examination, he has weak shoulder muscles and a purplish rash around his eyelids, a heliotrope rash. That's classic dermatomyositis. Blood tests show raised creatine kinase and specific antibodies like anti-Jo1 signal a risk of lung disease. Complications can be severe: aspiration pneumonia from weak swallowing muscles, interstitial lung disease, and in dermatomyositis, an increased risk of cancers like ovarian or lung cancer. That's why whenever dermatomyositis is diagnosed, cancer screening becomes an essential part of management. Number 4, rheumatoid arthritis, sometimes considered an overlap CTD. This condition mainly targets joints, causing chronic inflammation of the synovium. It begins insidiously, often with morning stiffness, swelling of small joints, and gradual deformity if untreated. Picture a 40-year-old woman with painful, swollen fingers who notices her rings no longer fit. Over years, her hands drift sideways with ulnar deviation, a classic deformity of rheumatoid arthritis. But it is not only joints. Rheumatoid arthritis also causes systemic complications: vasculitis, lung fibrosis, and even pericarditis. Anti-CCP antibodies in blood strongly predict more aggressive disease and faster joint destruction. The burden of untreated RA is immense: loss of mobility, severe pain, and disability. Fortunately, modern DMARDs and biologics, when started early, can halt progression, reduce complications, and restore quality of life.